Well, happy Friday, everyone, and welcome to this really special webinar that we have planned for you. My name is Dave Choksi. It's my privilege to get to welcome you all as chair of Common Health Coalition. The coalition is dedicated to strengthening partnership between healthcare and public health. And what we have today in partnership with the National Press Club Journalism Institute, as well as the New England Journal of Medicine Catalyst, is really a showcase of some of the leaders and some of the institutions who are modeling that partnership. The coalition believes that historically, this type of work has suffered from a poverty of implementation, not of ideas. And so our aim is really to be able to show how this work is already occurring and how we can spread it further and faster across the United States. It's my privilege now to get to pass the baton to Ed Pruitt, who serves as editorial director of the New England Journal of Medicine Catalyst. Over to you, Ed.
Thanks, Dave. So I'm Ed Pruitt, editorial director for NEJM Catalyst. As Dave said, I initially, I first attended the National Press Club as a junior reporter in the late 80s. So it's fun, a privilege to come to you today. NEJM Catalyst is a spinoff of the New England Journal of Medicine. So it's a scholarly, peer-reviewed publication. And some months ago, we put out a call for submissions for papers around public health and care delivery and the intersection thereof, because as is well known in the field, that intersection is more often a barrier. So we got a lot of submissions in, and we have published the best. And there are authors from almost every paper, authors represented here today from almost every paper that we published that went through rigorous peer review, read by multiple experts around the world. And we were able to publish the best. And so what you see here today are people talking about infectious diseases. They're talking about maternal and maternal care and abortion post-Dobbs. We published an article from the Centers for Disease Control on IT or on data needs. And I think a theme that is all throughout these different papers is the great need for coordination, for data, for working closely with care delivery systems, not viewing public health as a silo, and for really overcoming a lot of the barriers that harm healthcare. So we work closely with our guest editor, Nick Stine, and I'm honored to turn it over to him now. Thank you.
Thank you, Ed and Dave, and to the sponsors of this event. We have a really wonderful collection of people, leaders, thinkers about these issues, and a lot to, I think, share across the board there. So we'll try to move through a chance to give each of them a chance to say a few words, and also try to move along to cover some of the key themes that we wanted to today. But I just want to thank everybody who's joining, both on the panel and from outside. I think it's such an important conversation. It's clearly near and dear to all of our hearts and the work that we do. As a physician, I sort of have always felt like I've been in my work trying to trick healthcare into doing public health and to sort of break down these barriers that have existed for a long time, because fundamentally we know that solving these problems takes a lot of different vantage points, stakeholders, and we really need to follow the data to how we move the needle on that. And sometimes that isn't always in proportion to how things are resourced. And so it's up to us as leaders in these different spaces to figure out how to break through, how to really move together toward the common goals that we share, regardless of where we sit in the ecosystem. There's also, a strong theme in a lot of these papers in this really great issue of pandemic response. That's obviously been such a formative dimension to how we do this work over the past several years. And, while it can feel sometimes like we talk too much or too little about COVID, I think we really have a duty to seize this moment in this post-acute phase in the pandemic to really understand and learn as much as we can about when did these barriers break down, why, what worked, what didn't, and how do we take, there were a lot of really difficult challenges in the pandemic from a public health perspective, but also a lot of really inspiring moments of coming together and acting more as I think we would all want to across different stakeholders toward those common goals. So how do we learn from that? How do we distill that and bake that in a more sustainable way going forward? I think is on a lot of our minds, and we'll hear from a lot of different folks who have tried to take that on in their communities and in their work. So what we're going to do for this first section, we're going to try to get through a general section and then get through a few themes to be a little bit more focused. And I'm sure with this group we could speak for quite some time in any number of these areas, but we'll try to stay a bit efficient on it. What I'll first ask is each of the authors that have joined us today to just sort of quickly, 2 minutes each, do a quick introduction of themselves and the paper that they contributed to this issue and what they think are sort of the key learnings from those. Unfortunately, our first, the first author I was going to hand it to, Dr. Jennifer Layden, could not be here today. Something came up last moment, so we wish her the best, and we'll have to incorporate from that publication on the CDC perspective, which I think is important to kind of knitting some of this more locally focused work together. So what I'll do now is I'll hand it to Dr. Mary Mercer in San Francisco.
Hi, good afternoon or good morning, everyone. My name is Mary Mercer. I am an emergency physician and the chief of the medical staff at San Francisco's public hospital, which is Zuckerberg San Francisco General Hospital and Trauma Center, as part of the Department of Public Health there. I'm excited to be here and learn from my fellow panelists and share our system's story, which is about a unique partnership across our public health and healthcare delivery systems that helped us achieve one of the lowest mortality rates and highest vaccination rates in response to the COVID-19 pandemic. And Nick, do you want me to continue with just a high overview on that? To clarify?
Yeah, I think just a brief punchline, and then hopefully we'll be able to dive in a little bit more.
Sure. And so, as many of you know, San Francisco is geographically small and a very dense city with great cultural, ethnic, and linguistic diversity. And we're also located on a major and very active fault line in the Bay Area. So we live with constant awareness of the impending big one. And out of necessity from a disaster preparedness perspective, the San Francisco healthcare delivery systems have a decades-long tradition of coordinating and planning for emergency response with each other, and then also with the Department of Public Health. And the DPH, Population Health Group, facilitates monthly disaster preparedness forums with our hospitals and health systems. So I'm actually representing all of those partners today, including the San Francisco DPH, UCSF, Kaiser, Sutter Health, Dignity Health, Chinese Hospital, and the VA. And in early 2020, we built on these loose affiliations with a much more structured and goal-oriented planning and execution to respond to COVID-19. First, to expand our medical surge capacity and respond to our COVID patient surges, and then later applying similar principles to our collective response in distributing therapeutics and vaccines. And so there are 4 key principles that our collaborative was based off of. So first, establishing shared priorities and a first principles approach to guide our strategy and decision making. Ours were equity and speed. Secondly, defining clear governance structures to help ensure accountability and follow through up and down the chain of each organization and across organizations. And then ensuring data transparency for our metrics and outcomes that were relevant to those shared goals. And then finally, aligning the operational responses based on resources. And so one of the key takeaways we learned with bringing all of these organizations together to address the common goal is it's important to acknowledge that each organization might have different individual priorities or resources accessible, but they also have unique strengths. And so how each entity contributes to the whole response might actually be unique to what those resources are available. So you can balance what, one group might have a key community relationship, another might have more clinical staff. And so by having a values-based approach that's linked outcomes and accountability through timely data, your team can surface those strengths and capabilities much more easily.
Great, thank you so much. Yeah, there's so much that goes into these papers and this work. I realize it's difficult to capture it all, but hopefully it'll be a sort of tantalizing invite to follow up with the issue in the papers and keep these conversations going. So thank you, Dr. Mercer. Now also San Francisco, Dr. Susanna Graves.
Thanks so much, Nick. So the work that we did together with the Northeast Medical Services Clinic was really because we had this shared priority of reducing the number of TB cases, tuberculosis cases in the population served by their clinic. They provide primary care to a significant proportion of the individuals diagnosed with TB in San Francisco each year, over 90% of whom are born outside the US in countries with high TB incidence. NEMS is a local federally qualified health center that's been serving medically underserved populations in San Francisco and the San Francisco Bay Area since 1971. And their population they serve is 88% Asian and 80% served in a language best served in a language other than English, and 78% Medicaid eligible. So this is a very prioritized population for us and has a high number of TB cases. And their flagship clinic site is also located in the neighborhood that has the highest incidence of TB in San Francisco. One challenge in TB prevention is distinguishing latent TB infection from active TB disease, which are treated differently in patients who have a positive TB test. And we've collaborated for years on TB prevention, and in particular, getting patients through the cascade of care from risk identification to diagnosis to treatment for TB or latent TB infection. And my co-author, Amy Tang, is the Director of Immigrant Health for NEMS, and she identified at one place their clinic really struggled to move forward to the next step of that care cascade was in diagnosis, particularly when there were abnormalities in a patient's chest x-ray that made it unclear whether the patient had latent or active TB and might need more workup to look for active TB. We found that a specific risk stratification language in radiology interpretations supported provider decision-making around TB and latent TB and was really needed to move to the next step of that care cascade. So we collaborated with colleagues from UCSF, San Francisco General Hospital Radiology, and the California Department of Public Health to develop this. And also, as a takeaway, proposed that the future development of a radiology scoring system similar to the ones used for breast, lung cancer, liver cancer screening would be a very valuable tool to support diagnosis and treatment of latent TB.
Great. Thank you so much, Dr. Graves. It's really great work. All right, I'll pass it now to Ingrid Johansson from Minnesota.
Hello, everyone. So glad to be here with all of you today and to have learned so much from all of the other authors whose stories are incredibly inspiring to those of us working in this area. So very, very honored to be here. And I am a nurse by background. I'm the Director of Community Clinical Care for the Community Advancement Department in Minnesota for a large healthcare system called Fairview Health Services. And we are a large nonprofit healthcare system. We have more than 100 locations around the state, including hospitals and primary and specialty care clinics. And my team is a branch of our system that is really focused on advancing health equity through active collaboration and partnerships. And we enjoy a really rich network of community partnerships that we work with outside of the walls of our hospital and clinics. And really, aim to bring clinical services out into community and address social risk factors. We work on topics like or, urgent needs like food, accessible food, housing. And my team, specifically within this broader department, is focused on clinical services. So we're predominantly nursing-led and really focused on prevention efforts. And one of our best known programs is a vaccination program called MINI, or Minnesota Immunization Networking Initiative, that we've been running for, this is our 19th season, where we deliver free low barrier vaccines with trusted partners in hosted community spaces. And obviously this, this program and this legacy and these connections had put us in a really good position to respond quickly from an equity focus when the pandemic hit, but we lacked some really key essential logistical pieces for a rapid, massive scale deployment, particularly around really needed services in those early days like testing that people could trust and understand how to access and be served in their own language. So we were incredibly fortunate to be able to start a partnership with our local public health partners here, St. Paul Ramsey County Public Health, which is a large public health department. It serves our capital city of St. Paul as well as 18 other cities across their geography. And having a shared mission, a shared goal, but also acknowledging the pieces that we were missing and how together we could solve some of those problems. Our article really tells the tale of that collaboration and how we built that effort and how it grew from, kind of an urgent need into we're going on 5 years now of partnership, and we're really able to develop a process that at times we really functioned as one organization with community partners, with the local public health team, and with our health system and what we have to leverage as a large health system. And I just I'm really glad to be able to share these examples and ideas of how we built this, and then also just talk about how well this has set us up for future collaborations and targeting other concerning health needs in this post-pandemic environment. Thank you.
Thank you so much, Ingrid. And that the way people came together really came through in your paper in a way that I really appreciated and was encouraged by. Okay, I'll pass it now to Dr. Yolanda Pengetzi from Dallas.
Good morning and good afternoon, and thank you for having us. It's a pleasure being part of this panel. I'm Yolanda Pengetzi. I'm a pediatrician by trade, and I'm the Senior Vice President of Clinical Leadership at PCCI, which is the Parkland Center for Clinical Innovation here in the Dallas-Fort Worth area. And the paper we presented was about the pediatric asthma surveillance system and how our community came together to address pediatric asthma challenges and reduce health inequities in that specific disease. So as you all know, pediatric asthma is the leading chronic condition of childhood, and it was identified in 2019 in the Community Health Needs Assessment here in North Texas as the leading cause of pediatric morbidity here in Dallas County. So pediatric asthma is also a poster child of the importance of a collaboration between healthcare delivery systems and public health systems, in that to control asthma, we don't only need a child to have medications and to see doctors, we also need the environment to be controlled and the triggers in the environment to be taken care of. And that in and of itself can definitely give you a sense of the importance of that continuum of interaction. So the silos between those two systems do not serve the community well. So to address that issue during the Community Health Needs Assessment Implementation Plan for asthma, we brought together the Parkland Center for Clinical Innovation as a data support system, but also the Parkland Health System, which is the Dallas County safety net health system, as well as the Dallas County Health Department, a couple of federally qualified health centers, Los Barrios Unidos foremost health family health centers, as long as a couple of community-based organizations. And together, we built a program that would support these children across the continuum of care. And one of the key things we found out, lessons learned from this program, was that we needed to have solid data insights that was a common source of data so that we could bridge those silos and create those collaboration more inherently and in a more data-driven manner. And that's how we came up with the idea of the pediatric asthma surveillance system, which is basically a data dashboard that is community facing, that pulls data from the clinical side and from the social side and comprehensively puts it together into an index that gives you a sense of where the risk lies in the community and what are the risk drivers, both from the clinical side and from the public health side. And all those information give us a more comprehensive understanding of what's happening for the patient in the healthcare system. We have a better understanding of their ecosystem of risk in their community. And for the public health system in the community, they have a better understanding of how the patients healthcare interacts with that ecosystem to drive their risk. And that helped us actually build these cross-systems workflow in a more seamless manner. Now that we understood exactly what the risks were, we could assign the task and leverage each other's strengths from the healthcare system delivering the care in the context of the community insights, and from the community and the public health system delivering the public health interventions in the context of what's happening in the healthcare system. And truly that data bridge was essential because these data actually live in completely different areas, and bringing it together has been helpful. But truly one good consequence, positive outcome of this has been the fact that because the dashboard is community facing, other community partners are coming together based on this dashboard and engaging with both systems. So we're building a community collaboration just around the data that is driving outcomes here. And we've seen a 30 to 40% drop in asthma-related ED visits among children who participate in this program in those areas at high risk. And we've also had some interesting findings, like finding out that food insecurity in the neighborhood is a key driver of poor pediatric asthma outcomes. And one would think, but what would that how could that be? Asthma is a respiratory disease, but when a family has to choose between taking the child to the doctor, buying medications, and buying food, they will choose to buy food, and therefore asthma is going to fall on the sideline, and asthma control is going to be an issue. So it's been a fascinating endeavor, and I think the community has really pulled together. It's been very helpful for us to have this community-facing dashboard that everybody can lean on to understand, have a comprehensive understanding of what's happening to patients in our community, and then come together and create collaborations. We've seen environmental advocates reach out to use the data to advocate for environmental improvements in specific communities with the goal to improve asthma care in those communities. We've seen doctors in training come together and pull data from these platforms to enhance their advocacy efforts in the community. So it's really been an eye-opening outcome for this activity we put together.
Thank you so much, Dr. Pingetzi. The work that you guys do at Parkland is innovative in so many ways, and the innovation of PCCI. I know when Dr. Choksi and I were at the New York City Public Hospitals, we would often look to what you guys were doing for ideas and inspiration, and so please, if those of you aren't familiar with PCCI, please check them out. And again, there's a link to the article in the chat there to make sure to dig in more deeply on each of these programs and how they built them and what they learned. So thank you. I'll turn next to Dr. Alice Abernathy in Philadelphia.
Hi, thanks for the invitation to participate in the discussion today. Really excited to be here and to hear a little bit more about everybody's experience. I'm an OBGYN, I'm a health services researcher. I provide the full spectrum of obstetric and gynecologic care, and no doubt, like many of you, I'm living, working, and parenting in the midst of this massive disruption in really routine healthcare that resulted from the Dobbs decision. And this work really came out of that. While there have always been incursions on reproductive health care, Dobbs was sort of analogous to throwing gas on the fire. In many ways, Pennsylvania, which previously was viewed as maybe a more conservative state on the end of the spectrum in terms of reproductive health care and abortion care delivery, became an access point. And Philadelphia, almost a microcosm of the US, a progressive city replete with access points to care in an island of kind of the opposite. And the community involved in reproductive health care is very strong, resilient, they're accustomed to change, but this was sort of taxing to the limit. And I worked in collaboration with the Philadelphia Department of Public Health to see how we could integrate the needs of the people providing abortion care or contraceptive care, referring for these services, the advocates, those abortion funds directly funding that care, and see if we could craft a new supportive role for the department. And the way that we approached this was conducting a landscape analysis to methodically identify everyone that we could that was involved in reproductive health care in the city. So think Planned Parenthood, the ACLU, Women's Law Project, the various abortion funds, independent clinics, their physicians, major health systems in the city, other health centers run by the Department of Health, and other Title X grantees. So we conducted in-depth interviews with all of them and analyzed them. And the tools to do that are all in the article. And what we found was really a network of diverse clinicians and organizing, other collaborators. And they're all sort of working separately but together, focused on a common goal that was really encumbered by state regulations that were at odds with high quality and efficient healthcare. And many were worried about essentially a chilling effect that could be accompany Dobbs, in which providers would be worried about providing this care, patients wouldn't know how to seek it, and they were searching for an entity to counter a lot of misinformation that was circulating around reproductive health care. So the Philadelphia Department of Public Health stepped into that role, became a public advocate and a space for convening a lot of people with diverse interests and agendas, and really helped identify strengths and places that needed reinforcement. And it really became clear that public health departments are really uniquely suited to do exactly that.
Great. Thank you so much, Dr. Abernathy. Really great work. Okay, I will hand it to the last author joining us today, Dr. Marcia Wong from New York City.
Hi, yeah, just echoing everyone else, a pleasure to be here and to be part of this panel. I am Marcia Wong. I am infectious disease trained by infectious disease physician by training, have done a lot of HIV and STI work in the past, but currently work in the Department of Health, actually in disease investigation, outbreak response within congregate residential settings. And so our manuscript was mainly, as you've seen with so many other speakers, just the amount of novel infectious diseases that we've seen in the last few years, and that we will probably continue to encounter these sort of emerging infectious disease outbreaks. And often they do require novel countermeasures like medications or vaccines. And as we've seen, these are often initially with limited access and supply. So in our manuscript, we share our efforts to improve access to treatment and care during the 2022 mpox outbreak in New York City, where the new antiviral medication, tecovirimat, became available through a really complex CDC expanded access investigational new drug protocol for the treatment of mpox. So we did this through provider engagement, technical assistance, ensuring accessibility of medication supplies through home delivery services, connecting patients to treatment providers, and collecting and integrating data for decision-making. Overall, we had at least 1,200 patients who were prescribed tecovirimat, accounting for about 32% of cases treated in New York City. More than 95% of these prescriptions were filled through our centralized pharmacy process. And because of our data integration efforts, we were able to evaluate the percentage of people with mpox treated compared across race and ethnicity, and found that 39% of patients with mpox identifying as white were treated, compared with 31 and 30% of patients with mpox treated identifying as Black and Hispanic. And so I think the key aspects that we'll probably unpack in the discussion, but really, leveraging existing networks, and then, of course, key, accessing low barriers to access, centralizing processes, as well as really having data on hand and to really guide the public health response. Thank you.
Thank you, Dr. Wang. Well, great. So that was a sort of a quick whirlwind around the room to just give some context on folks and what they contribute to this issue. I did get a note that the first link shared is not the link to the free versions, open versions of the article. So we'll get that in the chat shortly so that folks don't have to worry about the paywall and digging in on this. So, all right. So what we want to do now is just sort of quickly go through a few themes that emerged in a lot of this work and give a few authors a chance to expand a little bit more on some of the lessons learned and their perspectives on them. One that we certainly have talked about a lot and thought about a lot and named a bit today is, a lot of this work came in the context of crisis, be it pandemic or other types of emergency response or, quick mobilization. And so I think the question is, if another public health department or healthcare organization wanted to replicate your program, what's a key piece of advice that you would give to help get them started to replicate it outside of the context where you did your sort of more unique innovation? And what challenges should they brace for if they were trying to build out based on what you've learned in being early into that space? So I'll first ask Ingrid Johansson to speak to that. So, if another county, another state, another group of stakeholders wanted to build something like what you have built, what would be key piece of advice, and what challenges should they have on their radar that you've learned through your experience is down the road?
Yeah, thanks for the question. And in thinking about this, and I feel like I have a lot of answers that might seem like common sense, but are really the secret sauce to how we were effective. And I have to just keep sharing this message that it's really about relationships. And so if you don't have any relationships, it's time to start making them. It's not too late, but if you don't have any relationships to leverage, it's going to be harder and take longer to launch a new response at another time of crisis or another urgent need that comes up for our community, or even just really tackling the extremely persistent needs and disparities that we see every single day in our work. I would recommend starting small and realistic. We're faced with really enormous challenges, and that can feel really defeating and overwhelming and discourage us from even launching. And so if it's just about a simple asset inventory, starting small with a narrow scope, you could call it a pilot if that helps. I feel like large cumbersome systems sometimes are far more comfortable with using that terminology of, this is a pilot, we're trying something, and you might get a little more buy-in from those in sort of the policy risk areas, when you frame it like that. And it also gives you an opportunity to, of course, apply some good, quality components to that of evaluation and revisiting the components of the program that you're piloting. And again, just like I said, I think we read a lot about in the other articles about the critical role relationships played in every example of successful outcomes for our patients and communities. So it's really not lip service, it's everything. And I think some of the pieces that were really important for us with our colleagues at St. Paul Ramsey County Public Health was getting out there together. So, it means, again, this might sound kind of cheesy, but turning on your cameras in meetings and shadowing at events, inviting your colleagues from across sectors to, a meeting or an event or a community convening, giving someone a chance to bring their diverse perspective and ideas from their organization, that will offer ideas for collaboration. And we're all people, so ultimately we need to develop trust and familiarity with each other to do our best work anyways, and that comes from sustained connection. So and then I think just really articulating the shared goal. Communication breakdown can be really disruptive to these efforts, and being really clear about, this is your job, this is our job, and kind of just those tenets of closed loop communication that we deploy a lot in healthcare, in our code blues, and where the stakes are really high, that it applies here as well, with just regards to clearly communicating. I think it's really important to just anticipate bureaucratic hurdles. They will come, they will be there from day one, and talk about how you might work through them. And I have to really give a shout out to the leadership from Fairview and the leadership from St. Paul Ramsey County for being very, very flexible and creative, and helping us work through some of those bureaucratic challenges that could have delayed implementation by months if they hadn't been as flexible and as willing to think creatively as they were. I loved how some of the other authors also shared a strategy that we implemented that and are actually actively a part of right now, with regards to having a contract, setting up a contract that has flexibility baked in from day one. Can it be somewhat open-ended? Can there be some language that will allow for a fast-tracked amendment process or a scaling up as needs change? This is exactly what we've done with St. Paul Ramsey County Public Health, and actually have a similar example with another wonderful partner, Minneapolis Health Department, with some contracts that are more flexible than your typical boilerplate, I think, government documents. And that took a concerted effort, and it's really played out to be a successful strategy and help us be more nimble and flexible. And then, I think I represent a healthcare system, and for those of you in this world, I think it's really important that you continue to champion that we need to broaden our definition of patient, of who our patients are. They are part of a broader ecosystem that has bigger impacts on their health and well-being than our healthcare alone can ever address. And we just have to own that and say that and show up with that in mind. And at the end of the day, all of our efforts will be more successful when we do acknowledge that and actually do the work that touches those broader upstream initiatives. And I have to also share that if you're struggling to get buy-in, or you're struggling to kind of think about what's the get, or when we all are living with really tight margins and tough times, this is a really engaging experience for your healthcare workforce. We have heard again and again that it's extremely satisfying. It's very meaningful for our employees to be working in these collaborative efforts. It refreshes, it inspires us, and it really resonates with us as to why we became healthcare workers. I've heard from colleagues that have, flexed time again to work on these collaborative teams out in community on these efforts with our partners in public health and community orgs, that it's helping inform their bedside work and their ambulatory care work, and it's improving their experience on that side of the wall, and it's also really helping honestly in the work that we're implementing with community and with public health, because the voices and the perspectives and the realities of what it's like on the front lines and within healthcare is really essential for informing the work that's happening out in community as well. So it goes both ways. And it really helps your colleagues feel connected to the bigger picture and, like I said, bring an important perspective to the work. So even just from an engagement standpoint, it's a positive experience. And then it's just ripe for creativity and for again, other ideas or other ways that we haven't maybe thought about tackling an issue together. Or I didn't realize that it could be some, just again, starting small or one small thing that we could launch together and then seeing how that can grow. Mini started with, really no designated funding and as a pilot with an extremely small group of partners. And that was 18 years ago. And here we are 19 years later with a very well-established initiative that is, a significant partner to our local public health and our state public health colleagues and teams. And I think that's been, again, I know for me as a nurse who started out in the hospital, and like you said earlier, Nick, I love what you said about you've been trying to get healthcare to do public health, or I don't remember exactly how you said it, but this has been I think just an incredible bright spot through the pandemic to see what you can do together. And so I would just, again, going back to the top of, start small with what you have and really work on those relationships. Thanks.
Ingrid, thank you so much. I really love those comments and perspective, and they certainly resonate that this is human work, and I think the things like the pandemic and Zoom, and there's so many things, and the size and complexity of this collaboration really make it, difficult to make it human and make that connection. But, there's a reason they say change happens at the speed of trust, right? Like those relationships are huge for getting things done and for finding our own purpose and meaning in this work. So thank you so much for sharing that. I think that's actionable too. I think all of us can, think about ways we can try to more proactively build relationships that will be really fruitful down the road in trying to do things together when we're not necessarily set up to have that be our first priority in our different stakeholders. Great. I wanted to pass to Dr. Mercer now, and same question about if another city or metropolitan area wanted to kind of try to build something. Really stands out the governance structure, the San Francisco Health Systems Collaborative, the maturity of that, and the way it seems to have served a really important function. What would you say as advice and challenges to another place trying to build something similar?
Yeah, thanks so much. And I'll just build off of what Ingrid said, and that, starting with relationships. And I'll add that what we tried to do was really strengthen bonds in kind of a structured, tiered governance manner from all levels of the organization, so that there were two natural ways. There were two groups of people were kind of loosely meeting together and building those collegial relationships already. And those were the emergency planners, like on the ground at each of the hospital systems with the Department of Health. And then the CEOs of the health systems routinely, like on a monthly or quarterly basis, would have a touch point for information sharing and collegiality. And what we realized in the face of, an emergent threat was that we needed to have our organizations be more responsive and collaborative. So two things happened. So we established these shared principles. So what are the principles that we all are on board with that can drive our collaboration? And those two principles were equity and speed. And then how can we align operations and clinical decision-making and operational decision-making in the service of those first principles? It was quickly realized that, the urgent need was to determine we had hospital capacity and surge capacity. So our CMOs and CNOs needed to be meeting regularly in a problem-solving manner in service of those principles. And additionally, once vaccines became available later on, our clinical, operational, our ambulatory care leaders, our pharmacists needed to be collaborating in the service of those principles. And so then, it's a unique structure in that our emergency planners, our emergency responders, our CMOs and clinical leaders were accountable to the CEO. So there was clear visibility up and down the chain of command, both within each organization and then across that, okay, we're moving to expand hospital capacity, determine where we can find a surge unit across our 9 hospitals in the city. So that was, the equity and speed. How can we make sure that one hospital isn't overloaded? So then that was a clear directive that we needed to be sharing data in more real time so that we could know which hospitals were overloaded, how we could perhaps level load our patients. And that executive sponsorship by the CEO is just knowing and reaffirming what the priorities were with their staff and their teams, then could help clarify which resources needed to be available. And I think similarly, we could check as the vaccine, I was in charge of our vaccine strategies across the city, and I'll just say we could check our decision-making and our resource allocation to those first principles. I mentioned at the beginning that each organization had their unique strengths and gaps. And so together by saying, okay, our problem is we want to efficiently and equitably deliver all of these vaccines to our communities and to ensure access to historically underserved or marginalized communities. How can we do that? So by grounding that problem in the first principles of equity and speed, it really made the case that we needed to have visibility into our outcome data. So how are we achieving the outcome for equity in terms of age, race, ethnicity, and even neighborhood? So when one health system, identified a potential site location for a vaccine clinic, if it wasn't serving a community that couldn't access it by public transportation or had other barriers to care, we could say, how does the first principle of equity get served with this resource outcome? So, and again, by having those problem-solving relationships across domains, as Ingrid was saying, really help to foster in a positive and reinforcing cycle, foster trust, foster faster decision-making in the service of those principles.
Great. Thank you so much. There's so much great work here in what you guys have done, and it's great to see the themes come through. I'll ask Dr. Wong from New York to chime in. Similar question. New York City's health department is well known for having really sharp folks and technical folks and some data that some other places don't have, that you were able to leverage and to sort of do surveillance and monitoring of the program once it was built as well. So knowing not every place has quite that same infrastructure, but similar goals, what would be the key pieces of advice and challenges to be aware of for other cities trying to do similar work?
Yeah, thanks for that accolade that I feel like sometimes is not as so well deserved but all the work here has just been like equally impressive, I think. But I think the 3 aspects that we really tried to highlight were, that emerged from really our mpox response was kind of in short, networks, and these same aspects have been echoed in the other manuscripts, but the networks and sort of low barriers to accessing whatever people need to access, as well as the data. And so just to sort of unpack each of these a little bit. So I think the first one, as people have mentioned before, the leveraging of your existing networks. So thinking strategically about what networks you might need to either provide services, get out messaging, whether that is to provider communities, which provider communities, or if there's messaging that needs to happen, the community-based organization partners that needs to happen in. Our team was more clinically focused and sort of leveraged our already existing relationships within, many of us were infectious disease trained within New York City. So we had this existing infectious disease network, as well as the relationships we had. We're a bit unique in that we do have a public hospital system. So leveraging the relationships. Many of those relationships were built during the COVID-19 response as well. So jumping from one response to another actually was helpful in relationally. We reached out specifically to safety net systems. So I think the themes of equity, particularly the federally qualified health centers, obviously the public hospital system, these safety net systems, as well as our own health department, sexual health clinics, to provide the targeted messaging and technical assistance to providers. So these obviously need to be maintained in non-emergency settings. And our health department is really large. It's 7,000 people. And, I think post-emergency response, we tend to go back to our silos. And I think it takes a lot of effort to sort of maintain that out of silo existence. And so I think even maintaining even within the health department and then externally with our community of providers, CBOs, is work and needs to continue to happen outside of emergency response. I will mention that one of our co-authors, Dr. Tristan McPherson, recently started a community of practice for our New York City infectious disease providers, which was built out of our mpox work. And, to continue to be able to expand our infectious disease networks and maintain and strengthen relationships that we really rely on when emergency responses arise, but need to be maintained, as so to speak, during peacetime. The second aspect is access, and I think this was sort of a big thing that I think was brought up as well. But when thinking about access, we really need to make these sort of novel countermeasures as low barrier as possible, and also to be brought where people are. Again, similar to the other two speakers for this discussion, we partially solved this by centralizing pharmacy processes and making sure that the pharmacy we had could do home delivery to anywhere within New York City. The biggest challenge with access to tecovirimat was sort of the number of physicians who were willing to prescribe, especially early in the outbreak, because it was a really onerous process, not reimbursed. Each patient would take 4 hours. Lots of paperwork. So sort of advocating for a telemedicine option, as well as simplifying the process so that more physicians could be onboarded. And that was work that was sort of done, between sort of our local health providers and then sort of advocacy up to, CDC and federal levels. So the key aspects of having a centralized pharmacy included using, as someone brought up before, that pre-existing contracts. So we did have a pre-existing contract that we actually utilized for our routine work in the health department clinics, and we were able to use that contract. So other jurisdictions who want to use this approach should really consider what contracts already exist. It's not super sexy to work on, but contracts are important, within their health department that can be deployed, sort of jurisdiction-wide during an emergency response. So our health department clinics are actually in process of renegotiating this contract. So it's important to put a clause to allow for flexibility, as was mentioned before, to be used during emergency situations. And then, for example, in addition to our current routine operations, we actually are considering using the same existing pharmacy contract that we use for mpox, that we use for the clinics, so that some of our recent migrant population, as well as people experiencing homelessness populations, can have access to Paxlovid for COVID-19 treatment. That's something we're exploring right now, again, using the same contract. Dr. Mary Foote, who's a senior author on this manuscript, is also working on a contract to find a pharmacy with more robust data systems that then can be scalable to much higher volumes than the contract. So, again, scalability, the volume that is needed for an emergency response. And finally, the data. I think really the centralizing of the pharmacy processes. We use the REDCap survey for providers to report initiations. So these two sort of data pieces allowed us to have robust data, and then we integrated that data into our surveillance data system. This integration was slow, really challenging, but in order to turn data into public health action does have to be timely. And ultimately, we were able to use this to evaluate what percentage of cases were treated broken down by race and ethnicity. So meaning that, what percent of cases identifying as white actually received treatment compared to what percent of cases identifying as Black were treated, et cetera. And this was something that most jurisdictions were not able to do. And so because, cases, mpox affected Black and Hispanic communities much more than people identifying as white. So to be able to break that down in that category was really helpful. So basically kind of, we weren't able to have this kind of data in time for public health action, so we're looking at it a bit retrospectively. But ideally, you'd be able to use this data to see gaps, and then sort of taking that back to sort of your leveraging your networks, going back to see what kind of provider outreach is needed, what relationships need to be built to fill those gaps, and then how do we build that trust among providers as well as the community. We did see a gap in one of the New York City boroughs that had a lower rates of prescribing, but it was challenging to work with the main health system serving that community. And so I think continuing to make and build those relationships now would be hugely helpful for future emergency responses. So I will stop there. Thank you.
Thank you so much. Yeah, I think we sort of set up some different themes to talk through here. And it's interesting how one way or another, the relationship seems to pop up in everyone. I think that speaks to what those of you who have really built this work have learned and we've talked about. So next, I think it would be, this event is hosted along with the Common Health Coalition by the National Press Club and the Journalism Institute there. So, I thought it'd be interesting to think about some of these issues, particularly from the journalism and communications dimensions of trying to do this work. I think certainly on the doing side of things, it can make a huge difference how this work is explained and covered and communicated to the public when we're trying to manage complex, nuanced information that may be actively evolving. And so I think, one thing that if we're thinking of the question with this group, what do we wish journalists would focus on in our work in that of public health and healthcare at large? And also, how can we in public health and healthcare do a better job communicating about what we're doing? I think there's skill sets that ought to be complementary represented here. To me, it's always, it can be frustrating when the reality of evolving and changing recommendations happens. And we know in our work, whether this is clinically with USPSTF updates or public health guidance around the pandemic or other situations that are unfolding before our eyes, I think it's really important to communicate that in a way that helps solidify and reinforce the reality that guidance must change. If we learn more, it's a good thing that these recommendations change because we've developed a better understanding of things. And if that in retrospect contradicts some of what was recommended earlier, that's not a I was wrong kind of thing. And we need to it's not a cause for a more skeptical eye. We want to be honest and aware of what the limitations of our recommendations are and what data that's based on. But it'd be much more concerning if guidance and recommendations didn't evolve and change with the data as it comes together. And that's a hard thing to communicate to the public and certainly with our patients when it feels like, you used to have to do this, now they say this, and I don't know what's going on. I think it's really important that we all kind of mutually reinforce the reality that this is a result of having a cold and clear-eyed allegiance to the data and a data-driven approach, and having the humility to evolve those recommendations as we learn more. And again, I think the opposite would be more concerning if it was just a stick in the ground that didn't move when we know a lot more. And I think that's because that's such a nuanced and difficult thing to communicate broadly at a population level. I think there's a huge role and potential public health benefit of journalism and communication, kind of helping frame that as a natural and even encouraging sign that these recommendations change over time. It's a difficult needle to thread, but I think we lose a lot of folks that don't quite understand why there are changes and think that it's a, there's one truth that is being sort of debated back and forth, but the reality being an evolving learning. And that our commitment in healthcare and public health is to continue to have an unbiased interpretation of the best data as best as we can, and trying to make that, with the help of the journalism side, trying to make that as clear and easy to understand as possible when the reality does have a lot of complexity to it. So we're going to have Dr. Layden speak to this a bit from the CDC perspective, but I also would ask Dr. Pingetzi to speak from her perspective. What in your work, what can journalists do to help with your messaging and efficacy of your program, and or what have you guys learned in trying to communicate this that maybe were lessons learned about how the communication comes from our side?
I totally agree with all what you said, Nick. It is important that the journalists actually support us in the process of communicating to the communities the importance of the changes that happen. And it's even more important when both systems come together and work cohesively so that the communication is consistent. So nothing comes out as controversy or contradictory message from one group to another. And from our work here, putting the data together across the continuum of care and using it to improve patient outcomes, we hope that it helps journalists in general. And I will not pretend to tell journalists how to do their job, but we hope it brings to them a comprehensive perspective of what a patient's journey is across the continuum of care, from the healthcare delivery system to the public health system and everything in between. And we hope, for instance, that when we look at the patient journey, we look at the different pitfalls that happens to them along the way in all aspects of the care, and we're more action-driven than grievance-driven. So we're more interested in finding those actionable items that we can fix. And what the past dashboard we have put together helps folks do is to identify those issues and identify the potential partners in the communities that can help solve these issues along the way, so that we can improve the patient health and the patient journey altogether. And what we're hoping is, we can drive the conversation again from, let's say, a child that ends up with a family that keeps going to the emergency room, and we find out that they haven't been taking the medication. That could be a very a story that could be a little bit judgmental, thinking of a family as one that doesn't abide by the doctor's recommendations or take their medications as prescribed. However, if we put the context around of a family that is struggling, that has food insecurity, that has to choose between feeding their family and buying medication, then that becomes a more compassionate story of a family that is struggling along the way and that needs some assistance. And if this is communicated back to the community, we might see folks, stakeholders step up and want to assist to improve not only the care of these specific families, but the community, and help us achieve our common goal of bringing health equity in the community, one patient at a time. But again, the way we tell the story matters, and having that comprehensive understanding of the patient's journey and of the provider's approach to care and the public health system approach to care, and the fact that we communicate with each other and we cohesively make those decisions together can help tell a different story of patient journey and of a specific community issue.
I think that's beautifully put and so true. I certainly have to be reminded a lot when I get deep in the data and excited about, numbers that, these are real people and the stories are incredibly compelling. And the more we can speak in terms of people's real path and journey themselves, it's far more broadly understandable and engageable. So I think you put it beautifully. Well, great. Well, hopefully, there'll be ongoing ways to have connectivity between, the press club journalist perspective and some of the perspectives here, because I know we certainly would love to learn more about how we can do that better, and and would love to help with how we get these messages right out there. And it's great that we're having this event together. I think that's very cool. Okay, the last theme I want to touch on with our remaining time, and we have a little bit in terms of our conversations about relationships being at the center of this success, and just to kind of dig in a little bit more on which relationships specifically did folks doing this work find unlocked some of that potential. Were there particular stakeholders or types of partnerships that that seem to be more effective at breaking across some of these barriers and collaboration? And also over time, you know, we know that there's plenty of turnover in all of these stakeholders in terms of the people you're working with. And I have, and I'm sure you all have had the experience of having built a really strong relationship with a stakeholder elsewhere in this ecosystem, and then that person moves on, and it feels like, how do I keep from losing what, you know, we were able to really do effectively together? So how do we build relationships, not just between people, but across stakeholders in a way that is sort of turnover proof or resilient, when we don't always have, you know, an extraordinary person in a key position? So yeah, I'm just interested in a couple of perspectives on the types of relationships and the durability of those relationships. And I'll start with Dr. Graves. It'd be great to hear your perspective on this.
Thanks, Nick. I mean, I think that's such an important theme here in terms of building these successful relationships between agencies, is the relationships also with the people who are working in them. You know, Ingrid had pointed out earlier the value of these relationships for staff engagement, and that is so true. So I think the relationships among leadership are very important, but so are the direct relationships among staff from all of the involved disciplines working on this together. The relationship that I developed with Dr. Tang, who's the Director of Immigrant Health for NEJM, has been, you know, one of the most inspiring and motivating relationships to me personally. And I know that the projects that the staff in our programs have worked on together have been the same for them. And, you know, together, our relationship with our collaborators at UCSF and also California Department of Public Health have just really been a place where we go for thought partnership when we run into challenges in our work in various facets of our work. So developing those collegial relationships with radiologists, but also for consultation and referral of patients, as well as community outreach and education, relationships that span multiple disciplines and where we're working on, you know, multiple facets of these projects together is really important. I think, you know, developing relationships around a shared priority is also really a core part of that. In our case, you know, starting with the shared priority of the inequity of the impact of tuberculosis that we saw in the community that we jointly serve was really the foundation of this work and of this relationship. And I do want to point out that the partnership between our organizations, between Northeast Medical Services and San Francisco Department of Public Health's TB clinic, really predated both my arrival and Dr. Tang's arrival in our respective roles, which was in 2019, less than 6 months before the advent of the COVID pandemic. Over a decade ago, our, you know, predecessors in our organizations identified that TB was impacting this core population served by NEMS and brought this data to the attention of medical leadership there. And that really gets the point that Mary had highlighted about sharing information. Having that population level information from public health surveillance was really important in launching that partnership so many years ago and developing a shared priority around preventing TB in this population. And then having ongoing information exchange that includes NEMS sharing information about their progress and pitfalls in optimizing TB prevention care that's continued to be crucial for sustaining the ongoing work that we do together to optimize that care cascade. So sharing information, but also sharing resources. Marcia from New York City had outlined that leveraging existing service networks to get the whole package of what patients need. What patients needs has been a key part of this. So from the health department perspective, this has included providing consultation and referral of patients to our TB specialty clinic for those that need more advanced specialty care, and also providing training and technical assistance to support the development of that in-house capacity in the community, in the community clinic, to build toward fine-tuning and improving and supporting that role of primary care so that they can be the experts in managing the preventive care, which is really a core part of their work in the community. And then I think for us, sharing patients. For anyone who has done clinical work or outreach work, or really any work where you struggle to directly serve members of the community, especially those who are struggling to access services equitably, you've experienced how compelling it is to be sharing a case. Somebody whose case you're working on together. So collaborating around individual cases, being able to access, making sure that people can access care in a culturally sensitive setting with providers who speak their same language, where they feel comfortable to be able to work together on cases and see people get healthier, get better. And if we're following surveillance data, to be able to see your community getting healthier and getting better, that is just incredibly compelling, and it sustains and drives us to be able to share those individual cases and those communities that are where we're trying to enhance equity. And then another thing that hasn't, I think, been talked about yet, but is really about budgeting and funding. So I think in terms of sustaining the work, being able to seek sources of supplemental funding to supplement the work. Over the time that Amy and I have been working together, NEMS has successfully secured multiple streams of funding to support this work in their clinic. Initially, they had some charity funding from a commercial lab partner to support TB testing for uninsured patients. They also secured a mini grant from a community-based organization that was a pass-through from the CDC. And then later, they collaborated with UCSF and CDPH, and also with us, to successfully compete for a large grant from the CDC. That's a multi-year grant through the Tuberculosis Epidemiologic Studies Consortium. And having those external sources of funding, even the small ones, really help sort of focus these collaborations and sustain the being able to prioritize the work. And then aside from external funding, just budgeting to prioritize the collaborative work. So in our department, we have budget for having a tuberculosis clinic where we can receive consultations and do patient care. And that's not true of every health department. So being able to have the budget allocated for those collaborative roles where we're, sharing patients and sharing the work and training back and forth. And then in NEMS, there's this budgeted position of immigrant health director. This is also, not every clinic, not even every clinic that's serving a largely immigrant population necessarily has this role. So the leadership that identified this as a need and turned it into a budgeted, focused position also helps sustain that relationship over time and the ability to collaborate. Thank you, Nick.
Thank you so much, Dr. Graves. Gosh, there's so much in all of these that I'd love to dig into more. But I think we're getting a really nice kind of range of perspectives, and again, more in the issue, which we do have a link now that has free access to all the articles. So sorry about the earlier one if that's a barrier, but that's there, and please use it. And these are those kind of things where a lot comes together in a in a publication, and we have this moment of visibility and connection, and you know, I think the challenge is to keep building on that and keep these conversations progressing. I'll ask for Dr. Abernathy to give one last perspective on a similar question around. Ed, did you want to say something?
Yeah, Nick, I'd just like to follow up on what you just mentioned, that in the chat, Beth Francisco posted a link to the theme issue. This is a different link than was posted at the outset. This link it allows free access, and that is due to Common Health Coalition, which sponsored this issue and allowed NEJM Catalyst to focus on this extremely important issue. And our business model is subscription. So unless you had a subscription to NEJM Catalyst, you would not be able to read these articles, except for the fact that Common Health Coalition has made them free access. So that's great. We appreciate it. I just wanted to highlight that, and thanks CHC.
Great, thank you, Ed, and yes, thank you to the Common Health Coalition and to New England Journal Catalyst for convening this and bringing these issues to the audience that they merit. So Dr. Abernathy, for kind of the last thoughts on this around relationships, and you know, what you had a particularly unique and fascinating type of scope for what you guys did. So I'm very interested in what you guys learned about building those, and some of them, I'm sure, with some political charge to them, but trying to build trust across that, which relationships, and how to create some durability to them. What were your lessons learned on that?
Yeah, thanks for that question. So this project was unique in a lot of ways. I think we were very fortunate to benefit from the incredible insight from the PI on the project, Asta Mehta, who is the Women's Health Officer at the Philadelphia Department of Public Health, and then the head of maternal and child health, to recognize that though abortion has been politicized, ultimately reproductive health falls under the framework of public health. And there's so much focus right now on, obviously, the shameful disparities in reproductive health outcomes from pregnancy and earlier. But what we were really able to do was say a live birth only happens in just over 50% of pregnancies, that there's really this large other percentage that people experience, whether that's miscarriage or abortion or ectopic pregnancy, right? Miscarriage is the most common complication of pregnancy, ectopic, one of the most deadly, especially early. And that predominantly people who have limited access points early in pregnancy experience some of those complications. Or make a different decision about what to do with their pregnancy, because it really is a life-changing diagnosis. And approaching it from that way, and kind of building this narrative around a pregnancy diagnosis really shaping someone's life trajectory. These are all decisions based around reproduction, contraception access and delivery, and recognizing that these are supported by evidence was really helpful in building some long-lasting relationships and how to kind of approach the conversation. You know, I think we're also at a time where we're seeing how devastating some of the restrictions around abortion have been for people. And there's an ever more pressing need that recognizes some intersectionality of these crises related to pregnancy, whether that be associated with childbirth or inability to access reproductive health care, including abortion early on, or contraception to prevent an unwanted pregnancy. And it was kind of through building out that relationship that we are most successful, and engaging our allies or other organizations that worked in those spaces that had previously sort of been siloed as different problems, and coming together under that shared framework. And that allowed us, to have better insight into the ongoings at like the Maternity Care Coalition, March of Dimes, right? More like pregnancy focused groups. And then bringing in others that were focused more on contraception or abortion care. And, recognizing these are outcomes of pregnancy that one person could experience, each one at a different point in their lives. And having a shared understanding of that impact was really, really important for the longevity, I think, hopefully, of our work that we've done so far. And then I think willingness to understand how each of those pieces of the puzzle came together, and having the eyes of the Philadelphia Department of Public Health and a little bit more insight into some administration activities, like at the city government level, and being willing to travel to the state capitol and provide some evidence-based testimony around what we were seeing was also really critical. And I think that required a certain commitment of different members of our team to step outside of the role that they usually occupied, but the insight that they were able to provide about how this really is a public health problem was really motivating, and provided a lot of compelling narratives to some decision makers who may have not really understood some of the intricacies of how this care is accessed or delivered or funded, for that matter.
Great points. Thank you so much, Dr. Abernathy. So we covered, I think, a pretty broad ground there. I want to, before we wrap up, just give a chance if any of the panelists had any other thoughts or insights that they wanted to add that we didn't cover today. Just wanted to open it up for a moment in case anybody had something they wanted to add. And but I think I'm really pleased that we were able to get as many of your perspectives in. The only worry about how to manage this time was making sure that we were able to cover that. And I think we did a great job. You all did a great job. So I thought that was really, really wonderful. I think for those of us who are committed to population health, it's what's beautiful and inspiring about it is its breadth and complexity. What's really challenging about it is its breadth and complexity. And so to me, feeling like there are a lot of kindred spirits here, and give me a lot of energy and hope going forward that this work is happening, and that we have venues like this to compare notes and try to help each other move things forward. So really want to thank all of you so much. I really hope this is the first of many conversations with you all, for those I have not met in person. But we covered east, west, north, south in terms of who's represented here, which I thought was pretty neat. So I also want to thank Common Health Coalition, Dave and Chelsea, for convening this, New England Journal Catalyst, Ed and the team, the National Press Club Journalism Institute. This is just such an important and fun area to put heads together. So more to come down the road. You have the link to for those joining. Make sure you check out everything that's in the issue. And I hope everybody has a wonderful rest of their Friday and a great weekend.
Thank you.
Thank you.
Thank you.